Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as CDC. I'm Dr. Holger Schünemann, and I serve as Professor of Clinical Epidemiology and of Medicine in the Departments of Health, Evidence and Impact and of Medicine at McMaster University in Hamilton, Canada. I also direct Cochrane Canada and the McMaster Great Center here in Ontario. I'm delighted to be joined by my colleague, Dr. Andrea Darzi. Dr. Darzi serves as a project coordinator for Cochrane Canada in the Department of Health, Evidence and Impact at the same institution. We are both delighted to be with you today and to discuss the selection of a risk assessment model for venous thromboembolism prevention in hospitalized medical patients. This work is a result of work that has actually been funded by CDC, and it includes a systematic review and a risk assessment model identification exercise that we will be describing in more detail later. Before we begin, I'd like to go over a few points and helpful tips for joining this webinar, simple housekeeping issues. So upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio pin. All audio will be muted, also that of my colleagues. At the end of the presentation, there will be time for questions. To submit written questions, please use the question area of your toolbar. The presenters will respond to as many questions as time allows, and we will repeat the questions, spelling them out or reading them out, sometimes summarizing them. Today's webinar will last approximately 1 hour. Please note that the webinar will be recorded. So let's begin. I will start this presentation that I know you've already seen the title for. This is about a selection of a risk assessment models for venous thromboembolism in hospitalized medical patients. And I start with some disclosures that I have to make. One is that obviously I have several roles that I already described. I also will talk about guidelines, and I'm a board member of the Guidelines International Network. And we've received funding from CDC through Carner to do the systematic review and develop that risk assessment model. For Dr. Andrea Darzi, she's a project coordinator, I already mentioned that, and she's a member of the GREAT working group, which I also co-chair. The objectives for today's presentation are the following three. So first of all, we will be talking about approaches to developing risk assessment models. We will describe, after having provided some background, we will describe a mixed methods approach for risk assessment model development for VTE, venous thromboembolism and bleeding, and inpatients, hospitalized medical patients, and then describe how these findings can inform guideline development and clinical practice. So as some background, a little bit of background on the topic, much of this work is actually related to a large project that McMaster University, the McMaster Great Center has done with the American Society of Hematology that focused on developing recommendations as part of clinical practice guidelines on venous thromboembolism. There are a total of 10 guidelines that either have been developed or are being developed. 7 of them have already been published. And just to provide a bit more background, the goal of that was, as I said, to inform clinical practice through evidence-based guidelines, but not only focusing on health providers, but also caregivers and patients. And the reason for that is that VTE is a common and very serious condition that occurs in a variety of actual settings. There are treatments that are proven to work, but not necessarily used consistently. And there is a number of new medications. So in this context, we have developed new clinical practice guidelines on a number of different topics that are being assessed. And the conditions that we have addressed are obviously medical inpatients and prophylaxis in medical inpatients, but we have also focused on topics such as pregnancy, thrombophilia, heparin-induced thrombocytopenia, and VTE, or venous thromboembolism in cancer. As I said, 10 topics, altogether 219 recommendations that have been addressed. And as we recognize doing this work and this exercise, we realized that there are a number of systematic reviews, but not all of the existing evidence syntheses that we identified had really been helpful in informing the recommendations. So we had to do really a lot of new work, and that new work was informed by our systematic reviews. In fact, we developed a few new approaches along the lines of developing these clinical practice guidelines that had to do with, first of all, developing protocols for keeping systematic reviews up to date. This is shown on this slide. We have piloted reviews of the Cochrane collaboration that deal with making sure, as I already said, living recommendations and living systematic reviews. There's been work published in terms of how to then turn this into guidelines, and this is just shown here on these two slides. And as further background to this work, we have produced, as I already described, clinical practice guidelines with ASH, with the American Society of Hematology, that will be shown on the next slide. Actually, the next slide shows the screenshot of the venous thromboembolism that includes recommendations dealing with medical patients, dealing with a number of pharmacological as well as mechanical prophylaxis regimens. And these guidelines obviously include recommendations that address pretty much all of the main topics. I'll go on to say that for these guidelines, in order to assess risk in patients who are admitted to the hospital, we did review existing risk assessment models. There are primarily two risk assessment models that we had utilized for this work. One is the Padua model, and one is the IMPROVE model, that both allow determining what we call risk in a hospitalized patient on the basis of existing risk factors that are scored, and the combination of these scores lead to specific risk estimates. And typically, so for instance, in the IMPROVE VTE risk assessment model, so VTE standing for venous thromboembolism, typically what happens is that patients, once they are assessed, are categorized as low, moderate, or high risk. Then, as it comes to bleeding risk, we have also here the IMPROVE risk assessment model, and that risk assessment model also includes a number of risk factors for which patients receive points, and these points also then lead through a score to a percentage that predicts the actual risk over the duration of the hospitalization. Okay, so based on what we've actually shown, there are a number of research needs that that we have identified. First of all, that we needed to better inform baseline risk assessments, these type of risk assessments in both for thrombosis as well as bleeding in medical inpatients. So what we'd like to do now is hand over to Andrea, and Andrea will be speaking about objective 1 of our presentation today, that is the approaches to developing risk assessment models, before she will hand over back to me once she's finished with objective 1 and 2 for me to finalize this presentation.
Thank you, Holger. Starting with the first objective today, I will be discussing some of the approaches used to developing risk assessment models. To inform the American Society of Hematology guidelines on VTE, we conducted an overview of systematic reviews to identify and summarize evidence related to VTE or bleeding risk assessment models in hospitalized medical patients. We identified 15 risk assessment models, 8 of which were empirically derived using consensus guidelines, published data, and input from clinical experts, including the Padua model, which is one of the extensively validated models, as in it has been tested several times in populations other than the one it was derived in, and performed well. However, the point system was not evidence-derived. The 7 other risk assessment models were evidence-derived by identifying risk factors with predictive power, using data mainly from medical records. The largely validated IMPROVE model and the Wooler model included a general medical population in comparison to the others that included more specialized groups of patients. All these risk assessment models are a formal combination of multiple predictors from which risks of VTE can be assessed for individual patients. However, different methods of selecting the predictors have been adopted. For example, the optimum method entails including all potential factors in a model and assessing if they remain significant. This often leads to overfitting and results are not generalizable. Other methods of selection of predictors include statistical selection, such as forward or backward selection, where a software selects the final factors. Another issue is when factors are selected based on their eligibility at the univariate analysis phase. These methods may lead to overlooking certain factors that appear non-significant or non-eligible in a univariate analysis, but may show a strong association at the multivariable level. Interaction is also a factor to consider, yet it is often overlooked. In reality, assessing all potential interactions and choosing variables accordingly is essential. Others have attempted to find a balance between clinical and statistical significance by building on what is known in clinical practice and on the research done in the field. This leads us to wonder what an ideal risk assessment model is. An ideal risk assessment model is appropriately derived from all potential prognostic factors. It is externally validated and has undergone impact studies, and has shown to accurately identify patients at risk of VTE and reliably exclude those that are at low risk. This is essential to ensure optimal selection of patients that will most benefit from thromboprophylaxis and avoid thromboprophylaxing those with a higher risk to benefit ratio in terms of bleeding as a potential adverse event. Also, an ideal model should be clinically relevant, easy to use in clinical practice, and cost-effective. That is, a favorable cost to benefit ratio. Considering these factors, we used a mixed methods novel approach to develop risk assessment models for VTE and bleeding in hospitalized medical patients. The process was conducted over several steps, as you can see here. As a first step, we conducted a systematic review to identify all potential prognostic factors and assess their association with our outcomes of interest. Why a systematic review, you may ask? Well, most evidence-based risk assessment models that are developed using data sets are limited by the variables measured in that data set. That is not the case when conducting a systematic review. A systematic review allows us to assess multiple types of prognostic studies, including risk assessment model development, validation and impact studies, and prognostic factor studies. The Guide to Systematic Reviews of Prognostic Factor Studies by Riley and colleagues notes that many prognostic studies are published each year, and the variability in design, the factors measured, and the inconsistency in the findings make a systematic review an optimal method to better identify which factors have prognostic value. Therefore, we thought it was imperative to conduct a systematic review as a first step, as part of a great collaborative effort with both clinical and methodological experts in the field. We are proud to say it has recently been accepted in the journal Blood. Our systematic review aimed to assess adult medical patients not on thromboprophylaxis that are admitted to a non-surgical inpatient ward for an acute, critical, or chronic illness. The exposure we were interested in were the potential prognostic factors present on admission, with the aim of identifying whether an association exists with the outcomes of interest. Those included symptomatic or asymptomatic DVT or PE and bleeding, whether major or clinically significant. We looked at a time period starting after the index admission to 90 days post-discharge, where the risk is still considered higher than the general population. Through our comprehensive search, we identified 17 studies, 14 of which reported on VTE as an outcome and 3 that reported on bleeding. Despite the difference in number of included studies, the total number of patients was similar for both outcomes at around 150,000. As a second step, after identifying all potential risk factors and summarizing the evidence, we assessed the certainty in the evidence using the grading of recommendations, assessment, development, and evaluations approach, otherwise known as the GRADE approach. To do so, we first assessed the risk of bias in individual studies using different tools. We used the Quality and Prognosis Studies tool, or QUIPS, for prognostic factor studies, and we used the Prediction Model Risk of Bias Assessment tool, or PROBAST, for risk assessment model development or validation studies. We then evaluated the certainty in the evidence by considering the 5 GRADE domains: risk of bias, indirectness, inconsistency, imprecision, and publication bias. Depending on these factors, we designated the certainty in the evidence of each of the identified prognostic factors as high, moderate, low, or very low. We included 8 prognostic factor studies, 6 risk assessment model development, and 5 validation studies. The study designs included case controls and retrospective and prospective cohorts, some of which were multi-center. The studies were conducted in different areas of the world, as you can see here. For example, the Improve Investigator study included around 50 sites in North and South America, Europe, and Australasia. Let's focus first on the findings related to VTE. Through our systematic review, we identified 29 candidate prognostic factors. We divided these patient-specific and disease-specific factors into 4 categories: medical illness and patient history-related factors, functional-related and demographic-related factors, and laboratory and physical examination-related factors. Of the 29 factors, we identified low certainty in the evidence that there may be little to no association between risk of VTE and acute heart failure, past use of tobacco, respiratory failure, coronary artery disease, hormone use, and chronic renal failure. We also noted that there was moderate certainty in the evidence that sex probably has little to no association with risk of VTE. As you can see, low certainty in the evidence exists for association between risk of VTE and autoimmune disease, central venous catheter use, severe stroke, history of heart failure, present use of tobacco, varicose veins, and obesity. There was moderate certainty evidence that the rest of the factors you see here were found to be probably associated with risk of VTE. Some of the factors that were identified to be probably associated with risk of VTE have been included in previous risk assessment models, such as age greater than 60 with an odds ratio of 1.34, immobility with an odds ratio of 3.17, or paresis, defined as lower limb paralysis within the past 6 months with an odds ratio of around 3. However, some factors such as elevated C-reactive protein or CRP with an odds ratio of 10.10, tachycardia with an odds ratio of 2.48, and fever with an odds ratio of 1.88 have not been included or considered in previous models. The same goes for medical illness and patient history-related factors, such as previous history of VTE with an odds ratio of 6.08, thrombophilia with an odds ratio of 5.88, past malignancy with an odds ratio of 3.2, and active malignancy with an odds ratio of 2.65. Infections were also found to be probably associated with risk of VTE with an odds ratio of 1.48. As for bleeding, we identified 17 candidate prognostic factors. Of those, we found moderate certainty evidence that there is probably little to no association between risk of bleeding and hormone use, and low certainty in the evidence that there may be little to no association between risk of bleeding and malignancy. We found that age, critical illness, central venous catheter use, and autoimmune disease were prognostic for both outcomes. Obesity and morbid obesity were associated with VTE and bleeding, respectively. However, only age, critical illness, and autoimmune disease had the same quality of evidence for the two outcomes. We identified moderate certainty evidence for most of the prognostic factors that showed a probable association with risk of bleeding, such as recent bleeding with an odds ratio of 5.15, gastroduodenal ulcers that has been diagnosed in the past 3 months had an odds ratio of 2.74. Also, we found low certainty evidence that autoimmune disease may be associated with risk of bleeding with an odds ratio of 1.3. After conducting the systematic review and assessing the certainty in the evidence using the GRADE approach, an expert panel that included clinical and methodological experts in the field provided input on the list of candidate prognostic factors for both VTE and bleeding as part of a Delphi process. The second and third meeting with the expert panel included presenting the evidence for which they made judgments on whether to include, potentially include, or exclude each of the prognostic factors from the final risk assessment models. The judgments were made in a structured manner by considering the pooled effect estimates, their associated certainty in the evidence, and other GRADE evidence to decision framework criteria, including resource requirements, equity, acceptability, and feasibility for each of the factors per outcome. Based on this process, and in comparison to other widely used models, we included 8 risk factors in our final VTE risk assessment model, including age greater than 60, previous VTE, infection, immobility, paresis, active malignancy, critical illness, and thrombophilia. Infection was an additional important risk factor that was considered in the Padua model, but not in the other risk assessment models. We identified 12 additional candidate risk factors that require further study, 5 of which were considered in other VTE models, including respiratory failure and heart failure in Padua and MYTH, severe stroke in the Padua model, and thrombocytosis and leukocytosis in the MYTH model. D-dimer was later added to the improved risk assessment model. However, we found that it still requires further study. As for our excluded factors, compared to Padua, we found that coronary artery disease did not predict VTE risk. And compared to MYTH, we did not include tachycardia as it was considered widely nonspecific. As for our bleeding risk assessment model, we included the following factors: age greater than or equal to 65, renal failure, thrombocytopenia, gastroduodenal ulcers, hepatic disease, recent bleeding, and critical illness. Our findings suggest that autoimmune disease did not predict bleeding risk due to conflicting results in the included studies. Also, we did not include sex, malignancy, and central venous catheter use that are included in the improved bleeding risk assessment model. However, we judged that these factors require further research. Let's look at a case scenario that suggests how these risk assessment models can be used in clinical practice. A young patient is admitted to the hospital for an acute infection. The patient is also known to have thrombocytopenia. No other VTE or bleeding risk factors were noted. Considering the final risk assessment models you see here, the weights of each of the factors included based on their pooled effect estimates, and assuming a baseline risk of 0% for both VTE and bleeding, this patient has a corresponding VTE probability of approximately 0.5% and a bleeding probability of around 0.7%. Holger will show you in just a minute when these risk assessment models can be used in clinical practice and how the findings can be used in a decision-making process. Our aim, by using a mixed methods novel structured approach, was to develop risk assessment models for VTE and bleeding in hospitalized medical patients that are evidence-based, clinically meaningful, relevant, and user-friendly. Back to you, Holger.
Thanks very much, Andrea. So I will be focusing on describing how these findings can inform clinical practice guidelines and clinical practice in general. So the idea here was to see, okay, how do our clinical practice guidelines actually, on the next slide, do inform, are informed by our use of the RAMs. So one way of dealing with this is the actual practice guideline that we had developed in 2018. One way of doing this was to match our findings to the ASH recommendations on VTE prophylaxis. So for instance, the prognostic factors we identified would have allowed for risk stratification by using the prognostic factor acutely ill or critically ill, which we can describe in just a second in terms of what that means by in terms of definition, and then identifying a matching recommendation. Going to the next slide. So going back to the actual calculated risk, if we advance this, the calculated risk that Andrea just presented of VTE, venous thromboembolism, with a probability of approximately 0.5% and the bleeding probability of about 0.7%, clicking twice, we can then utilize that information to balance the potential benefits and harms on the next slide. These benefits and harms are typically identified not only on the basis, advance please, not only on the basis of the actual health benefits. I ask you to click, and but also by how important these potential health benefits are, what it means in terms of cost, whether or not an intervention is doable. On the one hand. On the other hand, the potential downsides are the harms that a potential intervention inflicts, and in this case, it would be the bleeding as opposed to the prevention of VTE. The importance of that potential bleeding that we are seeing or that we might be seeing, whether or not costs are elevated, and whether or not an intervention is actually doable. So considering, first of all, the risk for bleeding as well as the risk of a VTE, the actual clinical practice guidelines on the next slide that, for instance, relate to acutely or critically ill medical patients would say the following. With regards to mechanical versus a combination of pharmacological and mechanical prophylaxis or pharmacological prophylaxis alone. I'm going to give you a quick example the recommendation number 6 in these clinical practice guidelines reads, in acutely or critical ill medical patients, the ASH guideline panel suggests using pharmacological VTE prophylaxis over mechanical VTE prophylaxis, and that is labeled as a conditional recommendation. And it is based on very low certainty in the evidence of effects of these two options that we are describing there. Recommendation 7 would say in acutely or critical ill medical patients who do not receive pharmacological VTE prophylaxis, for instance, as a result of an elevated bleeding risk, the ASH guideline panel suggests using mechanical VTE prophylaxis over no prophylaxis. And also that is a conditional recommendation. So next slide, what do these conditional recommendations actually mean? In fact, most recommendations, please click again, can be looked at like you look at a traffic light. And traffic lights, as you know, have green, yellow, and red lights. Most recommendations, click again, are yellow light type of recommendations. They are conditional upon circumstances, and oftentimes, like in the case of risk assessment for bleeding and venous thromboembolism in hospitalized medical patients, they depend on individual circumstances. Click again. That actually does mean that when they are conditional, users of these recommendations, both clinicians as well as patients, will require additional support with implementation. Click again, in simple terms, for patients, a conditional recommendation means the majority of people in this situation would want the recommended course of action, but many would not because of individual circumstances, and in particular values that patients assign to the actual outcomes that are affected by the interventions. For clinicians, it means that they should be more prepared in supporting patients to make a decision that is actually consistent with their own values. And in this case, decision aids and shared decision making may be particularly helpful. That sometimes is more complicated in hospitalized patients as it is in outpatients. Sometimes it's easier, and it depends on how we present this information. But if you go to the next slide, the idea, and click again, is really going from populations to the actual individual, the patient in front of us, if you click again, by considering these individual factors, click again, that lead to individualizing the risk for a patient. And this is primarily driven by baseline risks for instance, bleeding or venous thromboembolism, click again, and the potential, click again, for the potential outcomes that we are addressing. Okay. So, and clinical practice guidelines, indeed, these recommendations, if you click again, are directly related to what we can do with patient information. If we go to the next slide, we see what will be an eventual product of these particular guidelines. These are decision aids that help us with the implementation of particular recommendations, in particular conditional recommendations, that will support or are already supporting guidelines in general. These decision aids provide background for not only clinicians, but in particular patients as they may be facing particular problems. Next slide. They provide information about the actual risk that a patient might experience. For instance, here, this is a general recommendation where there would be information about for instance, how large the effect on mortality would be with or without prophylaxis, the actual effect on pulmonary embolism with or without prophylaxis. The certainty of the evidence rating is reflected there in the symbols and labeled as, in this case, high for these first two outcomes that we are seeing there. And there would be on the in many decision aids a actual recommendation as it would be provided by a particular guideline panel. This will inform patients and providers about typical patients. But what is really required and done by many risk assessment models is that the actual risk of an individual patient is individualized. individualized through calculation of individual risks. If you click now, that then includes both, first of all, determining how important particular outcomes are for individual patients. That relates to the key outcomes, in this case, addressed by venous thromboembolism. Obviously, all of these outcomes can lead eventually to death, but they also, with venous thromboembolism, comprises pulmonary embolism as well as deep venous thrombosis, and this is what is being predicted by our scores, as well as how important, for instance, it is for patients to have a bleed. Going to the next slide, in order to communicate with patients what is part of these decision aids that then help implementing our risk assessment models is a description of what we really mean by an outcome, because, for instance, communicating with the patient, but also with clinicians, of what a major bleed is that is considered in a decision aid as well as in a risk assessment model will require clarification, and we use something that is called health outcome descriptors in these decision aids that facilitate the understanding and make very clear and transparent what is actually meant. So, for instance, for a major bleed that the patient might experience in a hospital, it is described that one would lose a lot of blood. For instance, that could lead to vomiting blood. It could be losing blood with your stools and so on. And these detailed descriptions are necessary, we believe, in order to communicate information truthfully. Going to the next slide, as I said, once this is clarified, an individualization of the risk might help with clicking again, might help with then saying, okay, for a certain condition, the actual risk after I've identified these risk factors is at a certain level. Okay, I'm coming back to the case scenario just after having explained the use of decision aids. If you click again, that Andrea introduced, the calculated risk, again, with some venous thromboembolism, probability of 0.5% during the hospitalization, click, and a bleeding probability of 0.7%, click. And if you think of these two outcomes during a hospitalization, and would just say, which one is more common to occur? You would say, okay, the bleeding risk seems to be higher in an acutely ill medical patient with those risk factors that Andrea introduced there. And if we were just to look at the frequency, we would say we shouldn't prophylax these patients. However, as I described in the decision aid and the general approach, what matters is how important these outcomes actually are to individuals. So, for instance, if an individual places a higher value on the prevention of a blood clot, in other words, a DVT or pulmonary embolism, then that patient or the provider might appropriately choose to place the patient on VTE prophylaxis. Again, if patients place an enormously high value on bleeding, then obviously the alternative choice will be appropriate. If you click now, in a patient in whom that actual bleeding risk is deemed to be high or too high, or values indicate that the patient should not be prophylaxed, the alternative recommendation that is described here under recommendation 7, the alternative to pharmacological prophylaxis, might be appropriate. So not applying recommendation 6 because of an elevated bleeding risk would lead you to use probably recommendation 7, and that is that one would use as an alternative mechanical prophylaxis as opposed to pharmacological prophylaxis. That was actually already one question in the chat that I identified. So these guidelines also deal with mechanical or VTE prophylaxis. Going to the next slide. This type of information, these recommendations, in order to make them really useful, will be supported or are already supported in part by lay summaries that are targeted to patients or caretakers that, in very simple terms, provide both the recommendation as well as for whom this recommendation is intended. Click again, please. So having provided an overview of the actual research findings with regards to the risk assessment models that we have both compiled on the basis of the systematic review and the work with experts. We have drawn conclusions for what should happen next. First of all, there are existing risk assessment models, and as Andrea introduced, they are fairly similar to what we have found, but additional work is actually needed to see whether or not the additional risk factors that we have labeled as candidate risk factors really should be included in such risk assessment models. That would require representative populations, representative settings, further statistical validation, but more importantly, as is already done, integration of the risk assessment models in randomized controlled trials to ensure that the combination of the risk assessment model and the actual healthcare recommendations that have been developed in the context of the clinical practice guidelines, at the end of the day, lead to more desirable consequences as opposed to undesirable consequences, with a strong focus, obviously, on the patient-important outcomes. But cost, feasibility, and acceptability of the interventions play an enormously important role. This is, if you could please click, this has been work that we have done with, click again, please, with a large team of collaborators with support from a number of groups. First of all, again, we'd like to acknowledge the Centers for Disease Control and Prevention that has funded our work, ASH that has helped and supported meetings of the actual groups that have contributed to the work, that are also listed here, our clinical and methodological expert panel, invaluable input and collaborators that have made this work possible. They are listed there in the middle part of this particular slide, and then the research team that has made the systematic review and the surrounding work possible. We cannot be more grateful to that research team. Thank you very much for listening. We will come to our question and answer section that you can both type into the chat, and that we have already identified here. So a few questions that were raised, for instance, related to how we identified or how we defined critically ill patients, and I can answer that question very quickly. Critical illness was described as admission or transfer to the ICU or CCU, so intensive or critical care unit, patients on mechanical ventilation or respiratory, in other words, or heart failure that required intensive or critical care. That was the definition that we had actually utilized in this particular context. There were a few other questions, and I will ask my colleague Andrea to help with answering these questions as well. Andrea, you can see them on screen, and we can both moderate them. Yes. One of the questions was also related to mechanical prophylaxis, and I had already addressed that particular issue.
We had a question about thrombophilia. So we define thrombophilia as any known hereditary or acquired thrombophilia, including factor V laden, prothrombin gene mutation, protein C deficiency, protein S deficiency, antithrombin deficiency, and antiphospholipid antibodies. And what we did is we included all medical patients, whether acute, critical, or chronic. So I think that answers one of the questions.
There was another question how immobility was defined, and immobility, yes, in the studies that we evaluated was defined as either an order for bed rest or being bedbound in the hospital.
Yes.
Another question, just a logistic question, as we are identifying other questions throughout. There are quite a few in our chat here. Relates to sharing, whether or not we will share the slides. There are many of you who have asked that, and The slides will become available in phases. So first of all, the webinar is obviously recorded, but we will make slides available first for the systematic review and then for the risk assessment model and the expert study.
So there's a question about how the risk percentages were calculated in the case scenario. To put it in a simple format, really what we did was, once we had the pooled effect estimates of each of the risk factors, which were in an odds ratio form, we did a logarithmic transformation of each of those ORs in the model, which gave us the beta coefficients. We did the same for the baseline risk, assuming that the probability of VTE or bleeding at baseline is 0%. Once we had those numbers, depending on the case and the patient having an infection, we added the beta coefficient to the baseline risk, and we got a linear predictor. This linear predictor was put in a model, a logit model, to transform it back into a predicted probability. And that's how we got those numbers.
And so just to answer another question that was raised here, and Andrea answered it in part. So our risk assessment model, differently from many of the other risk assessment models, was derived on the basis of the systematic review and meta-analysis together with expert input, but the actual quantification of the risk is based on a meta-analytical approach, which is different from most risk assessment models, certainly the risk assessment models in this space, so in venous thromboembolism and bleeding, that are typically derived on the basis of cohorts and validation sets. So that is a very important difference in the approach that we've taken. So there's a few specific questions that relate to work that we might be able to share on the evidence to decision frameworks that we've done for prognosis. And we hope, this is a question from one of our colleagues, Dr. Ragusa, and that will be shared very soon. It's available in this webinar, but as soon as this work is published, we will be making this available for colleagues, and we probably would be able to make it available for research purposes already if you contact us. Go ahead, Andrea.
Yeah. So there's a question, what was the cutoff for thrombocytopenia? So the cutoff was a platelet count less than or equal to 150 times 10 to the power 9 per liter at admission. That answers that.
A question was raised, Andrea, that we can probably answer together. One of the questions is, what is the best risk assessment model to use? I think that answer is still outstanding. It's a difficult question to really answer. I think, first of all, what our work has shown is that existing risk assessment models, such as IMPROVE, are probably very accurate in terms of risk prediction. Our work suggests that there may be some additional risk factors that might be relevant. I think the actual risk prediction is not going to be very far off, but it is our risk assessment model will hopefully require further validation, or will require further validation in randomized controlled trials, combining them with clinical practice guidelines. So I would say ours, as well as the existing risk assessment models, are probably accurate and are all useful at this point in time. Time will tell which of them may be the most accurate one. So
yes, and assessing them in impact studies to see their effect on clinical outcomes is really essential at this point, as Holger said.
And so there's a question. There were actually two questions that related to surgical patients. I will emphasize that this particular work focused on medical inpatients, so hospitalized medical patients. So we have generally not included surgery as a risk factor. There was a bit of contamination in the studies of surgical patients, but we took care that this contamination in quotation marks was not too high, so that our model would not be biased by these patients. So that's the first point. And then family history did not come up as a risk factor in these models. That was also a question. And finally, an earlier question related to whether or not the Caprini score could be used in medical patients, and as to our knowledge, it's for surgical patients. So for the medical patients, it's the risk assessment models that Andrea described. There is a question about whether or not to recommend mechanical prophylaxis for surgical patients. There's lots of questions, and that's great, actually. Again, this has not been addressed in these particular guidelines. I refer you to the ASH surgical guidelines that provide guidance about surgical patients.
There's also a question on pregnancy. So we did not include pregnant women as part of our population. We considered that this is a subpopulation that requires their own risk assessment.
Yeah, there's a question about VTE in patients with cancer, the risk of VTE in patients with cancer, whether or not that risk will depend on the type of cancer. And I think we fully agree that first of all, there are other risk assessment models that further help quantifying the risk. As you know, the risk of VTE in patients with different types of cancer. That's number one. And number two, absolutely, that risk will differ by the histology or the site of the cancer. I think it plays a bigger role in patients who are then actually discharged, as this risk is probably cumulative over time, and the risk assessment models have looked at patients over extended periods of time, and the efficacy of prophylaxis in cancer patients, different types of cancer patients over time. What we know, this is slightly beyond this work, from the work that we have done, is that there probably, in terms of relative efficacy, there is little difference long-term with regards to the relative efficacy with regards to the type of cancer, and in particular heparins for VTE reduction, but obviously the baseline risk and therefore the absolute risk reduction differs.
There's also a question about cancer not being a risk factor for bleeding. Actually, we did find an association between malignancy and the risk of bleeding. However, through our process, we determined that it was one of the candidate prognostic factors that require further research prior to including it in a final bleeding RAM.
And one other question with regards to the definition of infection. This is actually an interesting side note. Many of you are asking questions about how we define the actual risk factors, and it became very interesting during this work that the various studies that had been conducted used quite different definitions. And therefore, as part of our work, in order to then also include the individual risk factors, we developed definitions of risk factors, prognostic factors, that can be utilized in other work as well. We didn't present it in detail here, but it will be part of research publications, which hopefully will lead to some harmonization of both reporting as well as measuring risk factors in studies and then integrating them in risk assessment models. And infections were, in other words, defined here as severe infections that required hospital admission, such as pneumonia, cellulitis that would require admission, meningitis, and sepsis, and there was obviously some overlap with critical illness. I
see another question here.
Yeah,
do you
take one
time?
more question.
Yeah,
we'll take one more question, and then I do believe there is lots of questions that hopefully can be answered also through the research publications. Then we'll come to end this session in just a minute. But Andrea, go ahead and answer that last question, perhaps.
Okay. So yes, so the question is whether the included studies included unfractionated heparin use. So to put it shortly, and as you said, it's all clearly described in the publication, but yes, some of the studies did include thromboprophylaxis, although we did not, this was not the aim. However, we accepted to include studies if the thromboprophylaxis given in the study was less than 10%, or if they were adjusted for in order to account for this, this variable. I hope that answers the question. So I think that's it.
Before we again end this webinar, I wanted to just again express our thank you to everybody involved, also to the organizers of this webinar. The final question is whether or not the studies included unfractionated heparin, and we have excluded that from our risk assessment model, or excluded these studies or adjusted for them in the analysis, if that was possible. So again, Dr. Darzi and I would both like to thank you, thank all of you for joining us today. As I said, also our colleagues at the CDC's Division of Blood Disorders, as well as the National Blood Clot Alliance for hosting today's webinar. Very shortly, you will receive an email asking you for feedback, so it would be wonderful if you could respond with your comments. If you have additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov. That will also be made available, obviously, or is available already. The webinar will be archived, and the content will soon be available at the CDC's Division of Blood Disorders website, as shown on the slide. If you could go, please, to the, yeah, that's the slide, wonderful. And if you go to the next slide, we are also asking you to join this webinar series again on June 18th, when Dr. Sujit Sethi from Weill Cornell Medicine will present update on novel thalassemia treatments. So please, join Dr. Seth for that very interesting presentation. And we again end this by thanking you for joining us today, and have a really great afternoon. Thanks so much.
Thank you so much.